All right, good morning, everyone. Thanks to those of you who are in person and those of you who are attending virtually online. My name is Ryan O'Malley. I'm from the University of Washington in Seattle. I'm chairing this section, which is GI imaging of the radiology review. As has been mentioned previously, we've made some substantial changes to the course design this year with the rapid fire cases and didactics mixed. So please let us know what you like and don't like about the format this year. With that, I will introduce our first speaker, Vincent Mellnick from Malignancies in St. Louis.
Thanks very much for the opportunity to kick off this great session. My topic today is rapid fire cases that involve inflammation and infection of the hepatobiliary and GI tracts. I have no disclosures relevant to this topic. So I'm going to try to get through about 15 cases in the next 20 minutes, and I'm going to try and present cases that I think can be difficult diagnostically or can be confused for things that are non-inflammatory. So here's my first case, a patient presenting to the ED with epigastric pain. The findings are a large outpouching from the posterior aspect of the gastric body with disruption of the normal mucosa, surrounding inflammation, and clot within the crater itself, and this is a large peptic ulcer as the cause for the patient's abdominal pain. Most of these that are benign present along the lesser curvature or posterior gastric wall if you're looking on CT. Remember that many superficial ulcers will not be visible, and so they really have to be deeply penetrating to cause a visible finding on CT. The findings when they are deep ulcers are, as these cases demonstrate, an ulcer crater with mucosal erosion, submucosal edema, perigastric fat stranding, and when perforated, extraluminal fluid and gas. It's important to scope patients with a new diagnosis of a peptic ulcer because there is some overlap between benign and malignant gastric ulcers. Here's an example of the latter where a patient similarly has an outpouching from the lesser curvature of the stomach, but also notice the presence of gastrohepatic ligament lymphadenopathy and increased FDG uptake on PET-CT in this ulcerated gastric cancer. The second case is kind of similar appearing. It's a patient who presented with epigastric pain. Initial interpretation was that of peptic ulcer disease. However, if you look carefully, notice that this patient has an oval fat density mass along the gastric antrum anteriorly, and that there's a linear area of increased attenuation within the mass itself. The endoscopy was negative, and this was later felt to be an omental infarct as the cause for this finding. And really it looks exactly like these examples, a fat or oval or rounded density lesion, most commonly seen in the right upper quadrant, such as in this example here. But remember, there is also a lesser omentum, so you can get omental infarcts than the lesser sac. It looks similar to epiploic appendicitis, although that's more common in the left lower quadrant, and a central high attenuation focus representing a thrombosed mesenteric vein can be seen. The treatment, of course, is anti-inflammatory medications. My third case is another patient with vomiting and epigastric pain that's been going on for some time. The findings on the CT are distal esophageal wall thickening representing esophagitis, hyperemic gastric folds, and a thickened duodenum, especially in the transverse duodenum where there are focal outpouchings anteriorly. And really, when you see ulcers in the duodenum that are post-bulbar, that is distal to the duodenal bulb, you should be thinking about two diagnoses. One is this one, which is Zollinger-Ellison syndrome. It's caused by a gastrin-secreting tumor causing mucosal ulceration in the stomach and duodenum. The CT findings are esophagitis and gastritis, as well as duodenal ulcers, and you may see a hyperenhancing lesion in the gastrinoma triangle, such as in this example on the right side of the screen. Again, when you see post-bulbar duodenal ulcers, you should think about ZE syndrome as well as Crohn's disease. Speaking of which, case 4 is somebody with right lower quadrant abdominal pain with marked thickening of the terminal ileum, which demonstrates submucosal increased T2 signal and diffusion restriction within the wall, as well as some ill-defined inflammation extending into the small bowel mesentery. And this is a person with active inflammation and penetrating disease from Crohn's. I could spend a whole hour talking on this subject, but very briefly, you should try to categorize people with Crohn's disease into 3 major phenotypes, that is, active inflammation manifested with increased T2 signal, surrounding inflammation and diffusion restriction, penetrating disease, manifested with an inflammatory mass, abscess formation potentially, and fistula formation, such as in this example of enteroenteric fistula. And then chronically, many patients will develop fibrostenosing disease, which has decreased T2 signal and causes obstruction due to strictures. My next case is someone presenting with vague abdominal pain and vomiting. The findings are pretty apparent, and they are low attenuation within the gastric antrum submucosa, as well as thickening of the duodenum and proximal jejunum. I think it's very easy in practice to sort of just throw out a generic differential diagnosis of ischemia, inflammation, or infection. One entity to think about, although not specific for this appearance though, is that of angioedema, and one classic offending medication is that of ACE inhibitors. This can be seen anywhere from 5 days after starting the medication to up to 9 years after beginning its use. The symptoms can be acute, as in this case, or patients may have recurrent abdominal pain. Usually the symptoms resolve after ceasing the medication, and often that's really the only confirmation we get of this diagnosis. We don't get pathologic proof that this is what's going on. The imaging features can be relatively nonspecific and include bowel thickening, mesenteric edema, and ascites. Note that pneumatosis and perforation is very atypical, and follow-up may be useful, such as in this case where a patient had nonspecific bowel thickening, mural stratification, and mesenteric edema. Their ACE inhibitor was stopped, and they had this negative CT 2 weeks later. Case 6 is a patient with right lower quadrant abdominal pain. Note the presence of a normal appendix right here. The findings, though, are of a blind-ending tubular structure arising from the pelvis with associated wall thickening and just a trace amount of fluid adjacent to it. So really the key to nailing this diagnosis is identifying that this is not the appendix, which the initial interpretation was that of acute appendicitis. The patient was taken to surgery, and this was found to be an inflamed Meckel's diverticulum, not an inflamed appendix. So remember that Meckel's diverticula are the most common structural congenital anomaly of the GI tract. People like to talk about the rule of twos. That is, it happens about 2% of the population, about 2% of people have complications. They're about 2 centimeters long and about 2 feet from the ileocecal valve. In addition to diverticulitis, in our index case, patients can present with hemorrhage. They can also present with torsion and obstruction, such as in this case here. The sort of white whale latrese hernia is demonstrated here, and they can also present with intussusception. And so remember Meckel's diverticula, especially in patients with right lower quadrant pain. Here's a patient with HIV presenting with weight loss and vague abdominal pain. The findings here are a little bit difficult to demonstrate on static images because they almost look like normal bowel loops, but if you look carefully, you'll see that there are multiple enlarged mesenteric lymph nodes, many of which have low density centers. So low attenuation lymphadenopathy broadly should make you think about either microbacterial avium infection or tuberculosis, seminoma or squamous cell metastases, or potentially Whipple's disease in people with nodular diffuse small bowel fold thickening. However, given this patient's history of immunocompromise, we really would hone in on mycobacterial infection, and that's what this ended up being. Remember that both MAI and TB may involve retroperitoneal and mesenteric lymph nodes. That low density center can be an important clue. TB can also present with peritoneal infection and GI tract involvement, especially the terminal ileum and cecum. We see this more commonly in patients with immunocompromise, and as I mentioned, you should think about this differential diagnosis when you encounter someone with low attenuation lymphadenopathy. Case 8 is a patient with profuse watery diarrhea and recent hospitalization. So hopefully the findings are pretty apparent, but they are a pancolitis with very severe wall thickening and submucosal edema. Notice that this has a very kind of nodular appearance. If we did a radiograph on this person, this is the corresponding finding for thumbprinting, and some people have described this as an accordion sign because it looks like this. And this degree of wall thickening really should prompt you to think about Clostridium difficile colitis. It tends to have more severe wall thickening than other colities, but you can see overlap in the imaging appearance, and so a mycobacterial workup is appropriate when you see this. Just to drive that point home, here are a few patients with different infectious causes of colitis. This older case of cryptosporidium colitis looks very similar to that C. diff case, but the distribution may also help you, such as in this patient with syphilitic proctitis, or in this patient with Yersinia colitis affecting the proximal colon. Case 9 is a patient with right lower quadrant abdominal pain. I will tell you the initial interpretation of this study was appendicitis, and in fairness, the appendix is right here and there's a lot of inflammation around it. However, at surgery, they found a different diagnosis. And in retrospect, you can see that there's a rounded outpouching from the base of the cecum, and that the inflammation is really centered around that outpouching rather than the appendix itself, and this is a case of cecal diverticulitis. So in differentiating cecal diverticulitis from appendicitis, really the key feature is a focal rounded outpouching from the cecum. It may be helpful to look at prior studies to identify the diverticulum present previously. This has a tendency to happen more commonly on the right side in young patients or in Asian patients. And in older patients, you might find it difficult to distinguish between diverticulitis and cancer. The surrounding inflammation and fluid in the mesentery might point you more towards diverticulitis, whereas lymphadenopathy would really make you invoke the possibility of a colon cancer. Case 10 is a patient with low-grade fevers and vague abdominal pain. The findings are left portal vein thrombosis, low attenuation masses within the lateral section of the left hemiliver, and very mild inflammation associated with this colonic diverticulum. Now, I really like cases where you can sort of bring all the findings together and have one diagnosis. It's not always possible to invoke Occam's razor, but in this case, I think it's appropriate. And this person has ascending infection causing portal vein thrombophlebitis and liver abscesses. So portal vein thrombophlebitis usually happens in the setting of an ascending infection, classically diverticulitis, appendicitis, or cholangitis. They often have an adjacent liver abscess, which can be a helpful feature, as in this case here, again with portal vein thrombosis and multiple non-enhancing collections within the liver, some of which have a peribiliary or periportal venous distribution. However, in these patients, you should document resolution because associated hepatocellular neoplasms could be present and may masquerade as liver abscesses. My next case is a patient with an elevated bilirubin. You can see that they have multifocal intrahepatic biliary strictures, and that on their MR images they also have a vague area of increased T2 signal with delayed enhancement that's geographic and is consistent with fibrosis. And this is a patient with primary sclerosing cholangitis with associated liver fibrosis. PSC is, as you know, idiopathic with a strong association with IBD, especially ulcerative colitis. They tend to present with multiple biliary strictures that can involve both the intra and extrahepatic bile ducts. Chronically, this can result in fibrosis and cirrhosis with an increased risk of cholangiocarcinoma. And cholangiocarcinoma can be subtle, especially when it's the infiltrating ductal type, such as in this case here, which really only manifests with wall thickening as the only clue to the presence of cholangiocarcinoma. I also think it's important to remember that not every case of multifocal intrahepatic strictures is PSC. We have a tendency, especially if you read ERCPs in your practice, to call every patient with multiple strictures a case of PSC. Well, remember that you can get SSC, if you will, or secondary sclerosing cholangitis from sclerotic metastases, such as in this case with someone with pancreatic cancer, multiple liver mets, and multiple biliary strictures, or in this subtle case of multiple biliary strictures in a patient who's had a liver transplant and whose arterial anastomosis is occluded, resulting in biliary ischemia. My next case is a patient presenting with abdominal pain. The findings in this case are that of an enlarged liver and spleen, and both the liver and spleen contain multiple low attenuation lesions. The lesions are larger in the liver and more confluent, and a little bit smaller and rounded appearing in the spleen. And when you have multiple liver and spleen lesions, you should think about a few diagnoses. In an immunocompromised patient, although usually smaller lesions than this, you can see disseminated fungal infection. Sarcoidosis is a reasonable possibility here, and potentially metastatic disease. And this actually ended up being a case of hepatosplenic sarcoidosis. You can see this relatively commonly in patients with sarcoid. The findings may simply be hepatosplenomegaly, and that's actually the most common presentation, but you can also see nodules in the liver and spleen in up to 10 to 15% of patients. As the nodules increase in size, they become more confluent, and you may also see abdominal or pelvic lymphadenopathy. Again, this is the differential diagnosis I would think of most often when I see multiple liver and spleen lesions, and so it's important to get clinical history to provide the most likely diagnosis, but ultimately you may have to biopsy either a lymph node or potentially the liver or spleen if there's no accessible lymphadenopathy. Case 13 is a patient with abdominal pain. It's been going on for years. The finding is probably pretty obvious, but I'll point it out here that there's a large spiculated appearing mesenteric mass with areas of calcification. Notice that there is engorgement of the mesenteric veins and perhaps some mild bowel wall thickening. With a calcified mesenteric mass, you should think about a few diagnoses. One is sclerosing mesenteritis, of which this is an example. Carcinoid tumor metastasis of the small bowel could also appear this way, although it's fairly large. Metastatic disease from a calcifying primary tumor like papillary serous ovarian carcinoma, or perhaps treated lymphoma would all be reasonable considerations. As I mentioned, this is sclerosing mesenteritis. This is relatively rare and caused by chronic inflammation. Early in its disease course, it presents with infiltration around the mesentery that can give it a misty appearance with preservation of the fat around the vessels, which can be a useful clue. Eventually, it can encase and occlude mesenteric veins, such as in this case here. And again, in somebody without a known primary tumor or a history of lymphoma, you may have to biopsy this in order to differentiate carcinoid metastasis from sclerosing mesenteritis. Case 14 is a patient transferred in from an outside hospital with a history of pancreatic mass. There are multiple imaging findings here that are all important to getting this diagnosis correct, but ultimately, I think this patient's clinical history is what allows you to get the correct answer. The findings are a large oval collection or mass within the pancreatic body and tail. One subtle observation that's important is the presence of globules of fat within this mass. Notice an enlarged collateral here from splenic vein thrombosis and multiple nodular densities within the retroperitoneum. Getting a history of prior necrotizing pancreatitis would allow you to differentiate this from, say, an extensive pancreatic adenocarcinoma, which was how this was initially interpreted. This also would be an extensive lecture to go through thoroughly, but it is important that when you see a complication from pancreatitis to think about where the collection is it next to the pancreas or is it in the pancreas itself, and how old the collection is. Is it 4 weeks or less than 4 weeks old? And so patients with acute peripancreatic fluid collections can develop pseudocysts after 4 weeks, but patients with necrotizing pancreatitis can have intra or peripancreatic collections that are very heterogeneous in appearance and can contain fat, and ultimately in 4 weeks can mature into walled-off necrosis, and that's the diagnosis for this index case here, is that of a walled-off pancreatic necrosis. My last case is a patient who presented with an elevated alkaline phosphatase and bilirubin. The findings are a stricture on the ERCP, which is smoothly marginated with sort of a bird's beak type appearance of the distal common bile duct. This shape might make you think about more benign causes of biliary stricture, including pancreatitis. This patient underwent CT, which redemonstrates sort of that smooth tapering of the distal common bile duct. Not much in the way of a pancreatic mass, but sort of diffuse enlargement of the pancreas, which has an edematous appearance and a low attenuation rind around the pancreatic tail. Now, it's important to read pancreas protocol CTs as you see them, and I think that because of the stricture we called a mass here that probably wasn't present, got biopsied and the cytology came back adenocarcinoma. The patient went on for a Whipple procedure, and the specimen came back autoimmune pancreatitis. So it's very important that if you don't see a mass and you think it could be inflammatory, to potentially get an IgG4 and suggest this diagnosis. This occurs because of plasma cell infiltration, inflammation, and fibrosis with loss of normal lobulation and that characteristic surrounding hypo-enhancing rind. It's also important to remember that up to half of patients can have extra pancreatic manifestations. Cholangitis, sialinitis, RPF, and interstitial nephritis are some examples. So hopefully these cases are helpful to you, and thank you very much for letting me speak in this session.
All right. Thank you, Vinny. Also, thanks for the segue and plug for a dedicated lecture about pancreatitis. So that's what we'll do here. The topic is actually benign and pancreatitis. This is a didactic session. I have no disclosures relevant to this talk. So we're going to try to cover a lot of ground here in 15 minutes. We'll spend the first part talking about acute pancreatitis, specifically focusing on the revised Atlanta classification regarding the terminology and the subcategorization of the findings. Talking a little bit about the imaging, the complications, then we'll talk about autoimmune pancreatitis, followed by benign cystic pancreatic lesions and congenital abnormality in the pancreas. So acute pancreatitis is an inflammatory condition, can have a wide range of severities, and thankfully most cases are relatively mild with no risk of mortality. However, there is a subset that can result in organ failure or infected necrosis, and these have a very high risk of mortality, up to 30%. The most common causes are gallstones and alcohol, but in a middle-aged patient, you should always be on the lookout for adenocarcinoma. Per the revised Atlanta classification, diagnosis requires two of the following: abdominal pain consistent with pancreatitis, elevated amylase or lipase 3 times the normal limit, or characteristic imaging findings. And note in those three categories, if you have the first two, there's no requirement for imaging findings for a clinical diagnosis of pancreatitis. So what is the role of imaging in this setting? We can help clarify the diagnosis if the clinical picture is uncertain. We can help identify the cause, particularly cancer or stones. And most importantly, we can detect local complications for patients who are having unremitting abdominal pain during their admission, or potentially who have a secondary peak in their pancreatic enzymes. Ideally, we would perform the imaging 5 to 7 days after admission. This allows enough time for local complications to develop and for us to be most sensitive, distinguishing between necrotizing and non-necrotizing pancreatitis. If you image these patients too early, the risk is that CT will underestimate the severity. But that being said, many of these patients do get imaging early. There is also a role for ultrasound, particularly early and in patients who are presenting for the first time with pancreatitis, specifically looking for gallstones. So this is a screenshot of the ACR appropriateness criteria. You can see in this setting, 48 to 72 hours after the onset of symptoms, ultrasound is by far the preferred modality. So after 48 to 72 hours, contrast-enhanced CT becomes the preferred modality. As I said, this is the ideal time to image patients to detect local complications and pancreatic necrosis. Contrast CT is the only modality that's been consistently shown to have value in predicting the severity of the disease and the clinical outcomes. If you have a high suspicion for vascular complications, then you can consider a dual-phase pancreatic protocol CT. For patients who can't get IV contrast, then a non-contrast MR is better than a non-contrast CT. You'll see here, again, ACR appropriateness criteria, in this case 48 to 72 hours after the onset of symptoms. Contrast CT narrowly edges MR with and without contrast, primarily because patients who are acutely ill and in this setting have a harder time tolerating the MR. So now we'll talk about the subtypes and classification of acute pancreatitis, as I said, talking about the revised Atlanta classification. And the first major decision point on this flowchart is, when you have somebody with acute pancreatitis, is there evidence of necrosis or not? And so we'll sort of divide this up into two halves, starting with interstitial edematous pancreatitis, and everything follows after that, after you make that determination. Interstitial edematous pancreatitis is characterized by non-necrotizing pancreatic inflammation, and on imaging we see uniform parenchymal enhancement with no necrotic areas, although you may see the gland is diffusely hypoenhancing relative to a normal gland. Other secondary features are signs of inflammation include localized or diffused enlargement, loss of normal lobulation, and peripancreatic fluid or fat stranding, like you see in these two images here. If you have a fluid collection that develops within the first 4 weeks since the onset of symptoms in a patient with interstitial edematous pancreatitis, that is termed an acute peripancreatic fluid collection. These are always peripancreatic, never parenchymal, and they're typically homogeneous collections that conform to the retroperitoneal spaces and do not have a definable enhancing wall. In contrast, an acute peripancreatic fluid collection that persists for more than 4 weeks since the onset of symptoms now becomes a pseudocyst. And as you see in the images here, these are more well organized and have a well-defined enhancing capsule. These should have only fluid within them. If you see any soft tissue contents or fat, you should start thinking that it's walled-off necrosis, which we'll talk about in a second. And pseudocysts may also have a connection to the pancreatic duct that you can see on CT or an MRCP. So we've done the left-hand side of the flow chart. Let's move to the right-hand side of the flow chart in necrotizing pancreatitis. So on imaging, this is characterized by focal or diffuse areas of hypoenhancing or non-enhancing pancreatic parenchyma, which is typically less than 30 Hounsfield unit difference compared to normal enhancing parenchyma. And this can be pancreatic, the necrosis can be pancreatic, peripancreatic, or a combination of the two, like you can see in the lower right-hand image. If you see necrosis, generally we would divide these into less than 30% necrosis or greater than 30% necrosis. You see corresponding illustrations here demonstrating parenchymal, pancreatic parenchymal necrosis, peripancreatic necrosis, and a combination of the two. If you have a fluid collection in the first 4 weeks since the onset of pain in a patient with necrotizing pancreatitis, that's termed an acute necrotic collection. These are very complex collections. They have a variable amount of fluid plus soft tissue and fat components that you can see on the CT here and also on the MR with very complex debris within the collection. And as with the necrosis, these can be pancreatic or peripancreatic. An acute necrotic collection that persists for 4 weeks or more then becomes walled-off necrosis, like Vinny showed earlier. These have a well-defined enhancing wall with mixed fluid, soft tissue, and fat components within the collection. And one thing to note with the pancreatic version, this characteristically takes the shape of the normal pancreas in that location. One word about infected pancreatic collections. Any collection can be sterile or infected, although it's more common with necrotic collections. Wall enhancement is not a reliable feature. Like I've shown you in the previous cases, pseudocysts and walled-off necrosis both have well-defined capsule enhancement. The only reliable feature on imaging is the presence of gas. So if you see a pancreatic or peripancreatic fluid collection that has gas within it and there hasn't been recent aspiration or any other iatrogenic manipulation, you should raise a concern for an infected collection, which has very high risk of mortality. So now as a sort of summary slide here with our flow chart, if you see someone with acute pancreatitis, decide whether you think that there's necrosis or not. If you have fluid collections in interstitial edematous pancreatitis within the first 4 weeks, that's an acute peripancreatic fluid collection. A collection that persists for more than 4 weeks is a pseudocyst. By contrast, in necrotizing pancreatitis, a collection in the first 4 weeks is an acute necrotic collection. One that persists for more than 4 weeks is walled-off necrosis. Necrotizing pancreatitis can have parenchymal, peripancreatic, or combined manifestations for both the necrosis and the fluid collections. And for both categories, any collection can be sterile or infected, but look for the presence of gas. Vascular complications are also common in patients with acute pancreatitis, with venous thrombosis being the most commonly affecting the splenic vein, followed by the portal vein and the SMV. Pseudoaneurysms are less common, but are more risky for patients. Pancreatic enzymes can result in erosion of the vessel wall, and you essentially get a contained rupture, most commonly again in the splenic artery. And as I said earlier, if you have a high suspicion for vascular complications, consider doing a dual-phase pancreatic protocol CT. So as a quick summary here for reporting on patients who have suspected acute pancreatitis. Again, the first question is, do they have imaging features of acute pancreatitis? It's possible that you image people either too early or in mild forms and you won't see the imaging findings. If you do see the imaging findings of acute pancreatitis, is there evidence of necrosis? If so, is it less than or 30% of the gland? Is it involving the parenchyma, the peripancreatic tissues, or both? Are there fluid collections? And if so, have they been present for less than or more than 4 weeks since the onset of symptoms? And is there gas within the fluid collections? And lastly, are there extrapancreatic complications like venous thrombosis, pseudoaneurysm, biliary dilation, or biliary stones? So now we'll make a quick segue here to chronic pancreatitis, of which autoimmune pancreatitis is a specific version of chronic pancreatitis. Classic features here are an enlarged sausage-shaped pancreas with loss of the normal lobulation. Classically, there's a peripancreatic rind of soft tissue that's low attenuation on CT and low signal intensity on MR. They're both diffuse and focal forms of autoimmune pancreatitis. The focal form usually involves the head or the uncinate process, and like Vinny showed, can be really hard to distinguish from pancreatic adenocarcinoma. The one clue is if you see, like in this form here, a focal area of low attenuation, but relative lack of upstream dilation of the main pancreatic duct or parenchymal atrophy, that's more specific for autoimmune pancreatitis as opposed to adenocarcinoma. There are two types of two subtypes of autoimmune pancreatitis. Type 1 is the sort of classic IgG4 type with elevated serum IgG4. This typically affects older men and is a manifestation of IgG4-related sclerosing disease. So in these patients, look for other manifestations of IgG4-related disease like retroperitoneal fibrosis or inflammatory pseudotumor or renal parenchymal involvement. Type 2 is usually younger patients. These patients do not have elevated serum IgG4, so that's one thing to be aware of. And these patients have a higher association with inflammatory bowel disease. Both types have similar imaging features and have an excellent response to corticosteroids. And so the response to steroids can both be diagnostic and therapeutic. So like you see in this patient who had classic findings initially on presentation, was treated for 6 weeks, and now has a normal pancreas on CT. So now the next part of the talk is benign cystic pancreatic lesions, and we'll start with IPMN. These are characterized by cystic or saccular dilation of the side branches or the main pancreatic duct. The classic appearance is that they're multifocal and that they communicate with the main pancreatic duct, which is what helps make the diagnosis and distinguish from mucinous cystic neoplasms. There are a variety of different consensus guidelines that you can follow. The most common or well-known probably being the Fukuoka consensus guidelines from 2012. And this defines two high-risk stigmata that warrant surgical excision of an IPMN, an enhancing solid component and main duct dilation of 10 millimeters or more. The same guidelines also define worrisome features as specific features that warrant further evaluation with endoscopic ultrasound, and these are listed here, including size greater than 3 centimeters, thickened enhancing wall, non-enhancing mural nodule, etc. You can see that IPMNs come in a variety of different forms. They can be multilocular with main duct dilation, they can be unilocular and unifocal, they can be multifocal without main duct dilation, or they can be multilocular without main duct dilation. Mucinous cystic neoplasms are termed the mother lesion since they almost exclusively occur in middle-aged women. And these are macrocystic lesions with a few large cystic components. And importantly, to distinguish from an IPMN, they do not communicate with the main duct. There are malignant potential for all of these lesions, and so if you see mural nodules, thick septations, wall thickening, or eggshell classification, this should raise concern that you have a corresponding malignancy associated with the lesion. So for most of these patients, because there is malignant potential and they present at a relatively young age, most are surgically excised. Serous adenomas are termed the grandmother lesion. Most occur in women greater than the age of 60. The classic appearance being a multiple tiny cystic lesion or cystic components in a honeycomb or sponge pattern, with 30% of these having a central scar with calcification. The vast majority of these are benign with no malignant potential, but there is one pitfall. If you have enhancing vascular septations that predominate over the cystic spaces, then these can result in a solid appearance. And so you see, like in this lesion, very hyper-enhancing, hypervascular lesion with high signal on T2 weighted images. These are indistinguishable from a neuroendocrine tumor, and you essentially only find this out after they're surgically excised. The last topic here is congenital. So we have ectopic pancreas. This is any pancreatic tissue that lacks anatomic or vascular continuity with the main pancreatic body. Most of these are small and asymptomatic, and so we only see them incidentally. But it's important to know that they're subject to the same inflammatory and neoplastic conditions as orthotopic pancreatic tissue, like neuroendocrine tumors, adenocarcinoma, or pancreatitis, like in this patient here who was biopsied and subsequently developed pancreatitis. Usually these arise from the gastric antrum submucosa within 6 centimeters from the pylorus, but they've been essentially reported everywhere throughout the GI tract, solid organs, and the biliary tree. As I said, they're usually detected incidentally, so we rarely diagnose them prospectively, but if you see a rudimentary ductal system, like in these images here, on either MRCP or an upper GI, then that imaging appearance is pathognomonic. So that was the last part of my talk. Here are some selected references from which the content and some of the images have been pulled here. And thank you for your attention. I'll now turn it over to our next speaker, Erica Stein from the University of Michigan.
Good morning, everyone. I have a fairly big topic to try and cover, so we're going to get started here. All right, I have no disclosures. First case is a 57-year-old man with dysphagia and concern for achalasia. We have 3 still images from an esophagram. There's a dilated esophagus with air fluid level. There's irregular narrowing of the distal esophagus with shouldering at the margins. And what is not shown is that there was also severe dysmotility with absent primary stripping wave. What is the single best diagnosis? Primary versus secondary achalasia, reflux-induced stricture, or candida esophagitis? And the best answer here is secondary achalasia, sometimes referred to as pseudoachalasia. This is usually secondary to a malignant tumor at the gastroesophageal junction, which was the case in the example I showed. Secondary achalasia typically lacks a smooth and tapered narrowing that we commonly see with primary achalasia. So how do we differentiate primary versus secondary achalasia? Well, the length of the bird's beak can be helpful. A short bird's beak favors a primary achalasia. A longer bird's beak, usually longer than 3.5 centimeters, favors secondary achalasia. And in our case here, you can see that it was a fairly long segment of narrowing, about 3.9 centimeters. Case 2 is a 78-year-old man with an incidentally detected gastric mass. So we have several images from a contrast-enhanced CT. There is a solid 4-centimeter mass arising exophytically from the gastric antrum. It demonstrates heterogeneous enhancement. What is the single best diagnosis for this solid exophytic gastric mass? Gastric adenocarcinoma, gastric carcinoid, a gastrointestinal stromal tumor, or gastric lymphoma? So the best answer here is GIST. These are non-epithelial mesenchymal tumors. They most commonly arise from the stomach, but you can see them anywhere along the GI tract. And non-epithelial simply means that they are non-mucosal in origin. So typically the overlying mucosa appears intact, and you can see that in our case. When you see an exophytic or ulcerated gastric mass, you should be considering GIST. Case 3 is a 61-year-old woman with right upper quadrant pain, and we are asked to evaluate the gallbladder. At ultrasound, we couldn't find the gallbladder, but we did see a hypoechoic non-compressible mass near the gallbladder fossa. There was also this thin echogenic line here centrally, seen on both transverse and sagittal sonography, and it was thought this could represent collapsed lumen or mucosa, and the patient went on to CT. So sure enough, the abnormality at ultrasound corresponded to marked circumferential wall thickening of the distal stomach. There was no evidence for gastric outlet obstruction, and we did find a normal gallbladder. What is the single best diagnosis for the marked gastric wall thickening? Gastric lymphoma, gastric adenocarcinoma, gastritis, or linitis plastica? The correct answer here is a primary gastric lymphoma. The histology is usually that of mucosa-associated lymphoid tissue or diffuse large B-cell lymphoma. It can present either as a bulky mass or a diffusely infiltrative form. In either scenario, you typically have preservation of the perigastric fat planes. Gastric outlet obstruction is unusual. Despite the degree of wall thickening, the gastric lumen tends to be preserved. Case 4 is a 61-year-old man, and I'm going to hold off on the clinical history for right now. There are numerous enhancing submucosal small bowel lesions. This results in multifocal luminal narrowing with intervening small bowel dilatation. There are also hypodense masses in the liver, the spleen, and the right adrenal gland. And there's extensive mesenteric and retroperitoneal lymphadenopathy. So what is the single best diagnosis to explain the small bowel findings here? Peutz-Jeghers syndrome, familial adenomatous polyposis, Cowden syndrome, or metastatic disease? I'm going to give you the history now, which is a history of melanoma, so it makes the answer much more obvious. This was a case of metastatic melanoma involving not only the small bowel, but solid organs and lymph nodes. Small bowel metastases are much more common than primary malignant small bowel tumors. There are often multi-organ metastases at the time of presentation, which was the case in the example I showed. There are 4 routes of spread to the small bowel: hematogenous, intraperitoneal seeding, lymphatic, and direct extension. Case 5 is a 46-year-old man presenting to the emergency department with abdominal pain. We can see the abnormality in the right hemiabdomen with the bowel within bowel sign. There's layering of bowel wall and mesenteric fat and vessels. There is an elongated mass-like appearance on coronal reformats, and there was also upstream dilation of the distal ileum. So this is a classic case of ileocolic intussusception, and my question is for you is what is the most likely lead point in this 46-year-old man? Colonic lipoma, colonic adenocarcinoma, lymphoid hyperplasia, or this is probably a transient intussusception without a lead point. The most likely answer here is colonic adenocarcinoma. When intussusception occurs in the colon in an adult, if you don't see an obvious lipoma, the lead point is often malignant. When it occurs in the small bowel, on the other hand, these are usually transient and benign. The length of the intussusception is the most reliable predictive indicator of outcome. Those small bowel intussusceptions that are less than 3.5 centimeters in length rarely require surgery. In our case, the lead point was a 2.7 centimeter mass that turned out to be moderately differentiated adenocarcinoma. In retrospect, you can see it right there. Case 6 is a 73-year-old man with a possible mass seen on right lower quadrant renal transplant ultrasound. We have contrast enhanced CT and unenhanced CT images here. You can see there's pretty marked segmental wall thickening of the sigmoid colon, giving this classic appearance of aneurysmal dilation. There was no bowel obstruction, no pericolonic inflammation, and we partially imaged the upper pole of the right lower quadrant renal transplant, which was normal. What is the single best diagnosis for the marked sigmoid colon wall thickening, colonic adenocarcinoma, colonic intramural hematoma, infectious colitis, or post-transplant lymphoproliferative disorder? The correct answer here is post-transplant lymphoproliferative disorder affecting the sigmoid colon. PTLD has the highest incidence in the first year after transplant when immunosuppression is greatest. It's not surprising that it's more common with multivisceral transplant recipients when the degree of immunosuppression is greater. Remember this diagnosis when you see abnormalities in this specific subset of patients. Case 7 is a 43-year-old woman with a mass found at colonoscopy, and this is for staging purposes. So we see an eccentric low rectal mass extending from the 12 o'clock to the 6 o'clock position. There is loss of the hypointense muscularis propria at the site of the mass. There's a fairly large, bulky exophytic component. And in the left hemipelvis is an expanded tubular structure with similar T2-weighted signal to the primary mass. And here on coronal T2, you can really appreciate that tubular structure extending in craniocaudal fashion. What is the single best diagnosis to tie the findings in the rectum together with the abnormality in the left hemipelvis? Is this rectal adenocarcinoma with an elongated nodal metastasis, rectal adeno-CA with extramural vascular invasion, rectal adeno-CA with fistula to small bowel, or rectal adeno-CA with pelvic sidewall invasion? So the correct answer here is rectal adenocarcinoma with extramural vascular invasion. There was actually tumor infiltrating into a draining vein of the inferior mesenteric vein. A draining branch, sorry. When extramural vascular invasion is present, it automatically denotes T3 or T4 disease. The patient would go on to neoadjuvant chemo-RT. It portends a very poor prognosis. It's associated with higher risk of local recurrence, distant metastases, and death. In our patient, she already had liver metastases at the time of presentation. Case 8 is a 75-year-old man with right upper quadrant pain and mass detected at ultrasound. We see a large mass in the right hepatic lobe. On the dynamic post-contrast sequences, there is progressive enhancement. It's heterogeneous signal on T2-weighted imaging, and there is also overlying capsular retraction. So the single best diagnosis for this large mass in the right hepatic lobe with capsular retraction, consider HCC, metastasis, abscess, or intrahepatic cholangiocarcinoma. The correct answer here is intrahepatic cholangiocarcinoma. Of note, these can occur in both cirrhotic and non-cirrhotic livers. When cirrhosis is present, it's helpful to use the RADS classification system. So if we were to see a similar mass in a patient with underlying cirrhosis, we might use LRM to describe the observation, a definite or probable malignancy, but not specific for hepatocellular carcinoma. Case 9 is a 51-year-old man with right upper quadrant pain for 3 weeks and elevated LFTs. We see innumerable small bilobar hepatic masses. If we take a more close look, they are isoechoic centrally with a hypoechoic rim or halo. The patient then went on to CT, which confirmed the ultrasound findings. There are innumerable small masses. They were hypodense on contrast-enhanced CT, and the spleen was normal and non-enlarged. What is the single best diagnosis for the liver findings? Granulomatous disease, metastatic disease, lymphoma, or disseminated candidiasis? So the correct answer here is metastatic disease. Hepatic metastases are much more common than primary liver tumors. There are a variety of appearances at ultrasound that are listed here. But when you see this target or bullseye sign with the hypoechoic halo, it's a fairly common presentation for metastatic disease, commonly from lung and colon primaries. Case 10 is a 75-year-old man with abdominal pain and incisional hernia. We see pretty marked irregular gallbladder wall thickening with enhancement. There's also subtle low attenuation involving the adjacent hepatic parenchyma. And there's a small omental soft tissue nodule in the left lower abdomen. What is this best single diagnosis to tie all of these findings together? Acute versus chronic cholecystitis, gallbladder carcinoma, or xanthogranulomatous cholecystitis? The best answer here is gallbladder carcinoma. Interestingly, gallbladder lacks a serosal layer along the hepatic margin, so we tend to see hepatic invasion commonly. And the low attenuation involving the adjacent liver in this case was actually secondary to contiguous extension. A major risk factor for the development of gallbladder cancer is chronic inflammation, and gallstones larger than 3 centimeters actually carry a 10-fold increased risk for the development of gallbladder cancer. Case 11 is a 67-year-old woman with abdominal pain, and we are asked to rule out diverticulitis. We have images here from a contrast-enhanced CT in the arterial phase. There is a 3.2 centimeter hypervascular mass arising exophytically from the mid-pancreatic body, and there is no main pancreatic duct dilatation. What is the single best diagnosis for this hypervascular pancreatic lesion? Pancreatic neuroendocrine tumor, a renal cell carcinoma metastasis, pancreatic adenocarcinoma, or an intrapancreatic splenule. The correct answer is pancreatic neuroendocrine tumor. Some people are moving away from the functioning versus non-functioning classification. It's felt that all of these tumors secrete hormones to some degree, and it's just a matter of whether or not the patient is symptomatic. The classic teaching is that these are uniformly hypervascular tumors, but we know that's not always the case. Especially the larger the tumor, the more heterogeneous they tend to be. It's important to note, though, that sometimes these tumors may present at initial imaging as either a hypoenhancing or a cystic mass. Our case turned out to be a well-differentiated pancreatic neuroendocrine tumor. Case 12 is a 59-year-old woman with worsening abdominal pain, and if you're paying attention to Dr. Heller's lecture, you already know the answer here. We've got pretty extensive retroperitoneal soft tissue conglomerate displacing and encasing vessels. There's mild elevation of the aorta from the spine on the middle image, and there's no evidence of vascular occlusion. The single best diagnosis for this extensive soft tissue conglomerate would include metastatic lymphadenopathy, retroperitoneal sarcoma, lymphoma, or retroperitoneal fibrosis. And the correct answer here is lymphoma, more specifically a primary mesenteric lymphoma. The sandwich sign is used to describe the confluent lymphadenopathy on both sides of the mesenteric vessels. So the filling of the sandwich is the mesenteric fat and vessels, and the lymphadenopathy on either side is the bun. The classic teaching here is vessel encasement without occlusion, and when you see all of these findings, it's highly suggestive of lymphoma and typically non-Hodgkin's. Case 13 is a 65-year-old woman with new onset lethargy, weight loss, and diarrhea. There are bilobar liver masses. On the arterial phase, we see that they are hypervascular, and on the portal venous phase, there's washout. They become hypodense to the adjacent liver. When we look in the right lower quadrant, there is eccentric wall thickening of the terminal ileum. There is also abnormal stellate soft tissue in the adjacent right lower quadrant mesentery with associated calcifications. What is the single best diagnosis to tie all of these findings together? This is a case of Crohn's disease with hepatic adenomatosis, small bowel desmoid with hepatic adenomatosis, small bowel neuroendocrine tumor with liver metastases, or small bowel adenocarcinoma with liver metastases. And the correct answer here is small bowel neuroendocrine tumor with hypervascular liver metastases. The primary small bowel neuroendocrine tumor is often small and sometimes occult. The mesenteric metastases, on the other hand, occur irrespective of primary lesion size. They are often larger than the primary tumor, and they are often mistaken for primary tumor. They are associated with marked fibrosis and desmoplastic reaction. And in the example that I showed here, the abnormal stellate soft tissue in the right lower quadrant mesentery, this corresponds to the mesenteric metastasis, and this was actually our primary tumor, which we don't often get to see so well. Case 14 is a 79-year-old man in the emergency department, and there was concern for bowel obstruction because he had abdominal pain. So we looked at the colon. Everything was normal caliber. The small bowel was normal. We start running our checklist. We don't see any evidence of diverticulitis, no hydronephrosis. We're almost ready to close the study and move on when something catches our eye. And we see scattered small omental soft tissue nodules, so very subtle finding here. What is the single best diagnosis for the abnormality in the omentum? Peritoneal carcinomatosis, splenosis, omental infarcts, or peritoneal mesothelioma? The correct answer here is peritoneal carcinomatosis. And if we look a little bit more closely on the coronal reformat here, we can actually see it's subtle, but a real finding that was called prospectively, a solid mass in the cecum adjacent to the ileocecal valve. So that was the primary adenocarcinoma leading to the peritoneal carcinomatosis. With peritoneal carcinomatosis, we know search pattern is key. The omentum can be a blind spot for us. It's important to look for omental and peritoneal nodules on every case, not just our oncologic follow-up, but every case. If you see something abnormal, look closely for a potential site of primary malignancy. And our last case here might not be a common abdominal malignancy, but something that I thought was worth talking about. This is a 45-year-old man with an incidental right lower quadrant mass detected at MRCP. The proximal appendix is normal, you can see with the arrow. The distal appendix is abnormally dilated. It's filled with T2-weighted hyperintense material. There's also a more thick T2-weighted hypointense component laying along the dependent portion. So the patient went on to CT. This abnormal T2-weighted hypointense component corresponded to dystrophic calcifications. You can appreciate the distended distal appendix here, and there was no periappendiceal inflammation. What is the single best diagnosis for this abnormality in the right lower quadrant? Acute or subacute appendicitis with contained distal perforation, a normal appendix with an adjacent duplication cyst, carcinoid tumor of the appendix, or a mucocele of the appendix. And the correct answer here is mucocele of the appendix. That's just a generic term that refers to a distended or mucus-filled appendix. It can be associated with both benign and malignant pathology. On the benign spectrum is mucosal hyperplasia and mucinous adenoma, and on the malignant spectrum are the low-grade mucinous neoplasms or appendiceal adenocarcinoma. Occasionally, you may see pseudomyxoma peritoni, or jelly belly as some people refer to it. When a mucocele ruptures, you can end up with intraperitoneal accumulation of gelatinous ascites. And our patient went to the OR and pathology returned as a low-grade mucinous neoplasm in this case. Thank you so much for your attention.
Thank you, Erica. So our next speaker, is Cynthia Santillan from the UC San Diego, who's going to be talking about RADS.
Good morning, everyone. So we're going to be discussing RADS version 2017, and I'm going to borrow a phrase from my son that he uses when I ask him if he's cleaned his room. And he'll go, ish. So this is going to be about RADS version 2017-ish, and I'll explain where the ish comes in a little bit later. So my disclosure, I'm a consultant for Robarts Clinical Research. So the objectives of this 15-minute session is going to be to teach participants how to apply RADS to their interpretation, inform you guys about some of the changes in the newest release of RADS version 2017, as well as pointing you towards some of the updated additional content relating to ultrasound and treatment response assessment guidelines. So RADS has been a huge international effort now that's been going on for over 10 years now. Version 2014, which was the version that was prior to the version 2017 release, involved people that were in multiple different committees working on specialized content, such as tumor response, RAD path, reporting, and there was an effort that was not just international, but also cross disciplines. We involved surgeons, radiologists, hepatologists, both interventional and diagnostic radiologists, pathologists, in order to make sure that we were addressing all the needs of these various groups of people that take care of these very complicated patients. And the steering committee is led by Dr. Claude Serlin, which oversees and kind of coordinates much of the work that's being put together by all these multiple different groups of people. Version 2017 added content with regards to ultrasound, with surveillance ultrasound. We did include hepatobiliary contrast agents in version 2014, and we've maintained and updated that content. But there's also been content related to contrast-enhanced ultrasound added as well. So this was the version that was released in 2014. And those of you that hold LIRADS near and dear to your heart, remember that this table in the center of this diagram kind of represents kind of the heart of LIRADS, where we talk about things that are at least intermediate suspicion for hepatocellular carcinoma or other malignancies. So now we have three different types of algorithms, and almost kind of a fourth as well if you include treatment response. The CT-MR LIRADS released in version 2017, contrast-enhanced ultrasound LIRADS, and ultrasound LIRADS. Now mind you, these are diagnostic algorithms here, the CEUS and CT-MRI, in comparison with what is a screening surveillance algorithm, which represents ultrasound LIRADS. And so this is an overview of ultrasound LIRADS. It's simple, it's easy, right? You've got three different categories. Ultrasound 1, which is a negative, means it's an adequate examination with no focal observation, or you're seeing things that you can be very confident represent benign entities. US 2 is subthreshold, so those observations that are less than a centimeter and not definitely benign. And so those people end up getting a shorter interval surveillance depending on institutional practices. And then we have the positive examination. So an observation that's greater than 10 millimeters and not definitely benign, or if they see a new thrombus in vein, because we want to make sure that that may not represent tumor in vein as opposed to a bland thrombus. And so once you become positive in this algorithm, then you move to a diagnostic imaging algorithm, which is going to be either your CT-MRI LIRADS or CEUS, depending on what's available at your institution. And so this is a very simple algorithm in my mind, and just what is reflective of the incredibly hard work put in by the committee that developed this is the resulting beautiful simplicity from this algorithm. And so if you put this all kind of together in one sort of flow chart about how you move between the different entities, the different types of LIRADS, so you have a positive ultrasound screen, or you have what is not considered to be a appropriate multi-phase examination on CT or MRI for assessment of the liver, and you see something that doesn't seem quite right, then you move to a formal diagnostic test. Now, many of us sometimes just see things also in a multi-phase CT or MRI, and many institutions actually use these as the primary surveillance modality. So that's fine. If you start with a diagnostic test, then you treat it as a diagnostic test as well. And then moving from one algorithm to the next, and down here for the diagnostic testing entities, and if the patients had some sort of local regional treatment, an ablative procedure or an embolic procedure, then you use the treatment response algorithm, which has its own classification system as well. So this is the CEUS algorithm from version 2017. You'll notice that it's got we've moved towards a more vertical format for our algorithms, and you'll notice that this in many ways reflects the CT-MRI LIRADS as well. We want to keep the overall visual appearance consistent from one part of LIRADS to the next. And their table is considerably less complicated. The variables that you want to look at are the nodule size, the presence of arterial phase hyperenhancement, and the type of washout. Those of you that do CEUS know it's not just washout, it's when the washout occurs that informs us about what the entity might be in CEUS. And this is developed for those agents that are considered to be pure blood pool agents. There are some agents out there that are felt to be somewhat mixed, and we felt it was going to complicate things too much to include the variability associated with those agents as part of CEUS for version 2017. So this only applies to the use of pure blood pool agents. So this is the treatment response algorithm for version 2017, and we've got basically 4 different categories here. If the treatment response cannot be evaluated due to image degradation or omission, you have this non-evaluable option available to you when you feel, I really don't know what's going on because we screwed something up or something just didn't go right with the examination. And so that is an option that you can use when you don't feel the examination is adequate, and therefore maybe that person needs to get re-imaged or use a different type of modality that better suited for that patient characteristics. And then, but if we feel we've got a good examination, we have these 3 categories available to us. Non-viable, when we believe that the tumor's dead, they killed it. Equivocal, if we're not quite sure if we see residual enhancement, or probably or definitely viable. And then these are the ways that you can assess that. For viability, we talk about a nodular, mass-like, or thick irregular tissue in or along the treated lesion with any of the following: arterial phase hyperenhancement, washout appearance, or enhancement similar to pretreatment. And I'd like to point out at this point that I put this web address down here because all of these things are available at the ACR website. You can download PDFs or PowerPoint presentation that has all this material available to you. So I would encourage you to check that out, print it out, put it on your wall, frame it, however, whatever you'd like to do. And then, including with that content is, also kind of more specific content about how to do things like how do you measure the residua from an ablated lesion. And so we decided, to adopt what many other institutions have when they're talking about residual tumor. You do a measurement that does not cross any areas of non-enhancement. So you put a measurement down that however you can fit it so that it's only crossing viable tissue, and then that's the measurement that you report as far as the area of remaining viability. And if it could be a crescentic area like this or separate different nodules, you measure the biggest one that's associated with that treated observation. So these are the categories that were part of what is now known as CT-MRI LIRADS in version 2014. So we had LIRADS 1, definitely benign, that progressed to things that had increasing degree of concern for malignancy, up to LIRADS 5, which was definitely HCC, LIRADS 5V, an HCC associated with tumor in vein, or LRM, which was mentioned earlier, which is a probable malignancy but not specific for HCC. And then we had this kind of wastebasket sort of area, knowing that this algorithm was going to be fleshed out on the subsequent version. So version 2017 kept much of the same category progression, but we added a not categorizable area, which is similar to what we talked about in the non-evaluable waste bin there, for those times when we just don't feel we have adequate information to make an intelligent assignment of suspicion related to that observation. We see something there. We know there's an abnormality, but for some reason we couldn't get a good arterial phase or something else went wrong. You'll notice here that also that we've taken away the LIRADS 5V category, and we have now replaced it with an LRTIV, acknowledging that it's not always just HCC that can have vascular invasion. Other malignants can also have that, including cholangiocarcinoma. And so we've now moved to this characterization of tumor in vein because in many respects, a lot of treatment options are shut away from that patient once they have vascular invasion, regardless of the primary tumor type. Now, you should be expected to look at what's going on in the parenchyma and say, I think this is tumor in vein, likely secondary to an HCC, or likely due to a cholangiocarcinoma. Sometimes you may not be able to tell, though. But if you make this specific observation, that really has a lot of implications for patient management. And so this is the version 2017 that was released in June of last year. And you'll notice, we have the progression of the different assessment of categories. We have this table where we talk about, the moderate, intermediate suspicion to high suspicion observations, and we'll talk a little bit more about this. But, we're friends, right? We're going to keep this all amongst ourselves because I'm about to show you something I'm not totally sure I'm supposed to show you. So, hold on. I'm just going to skip to that because I want to talk about it. All right. This is version 2018. And you're like, what are you doing to us? You just took out version 2017. And I know we really promised we were going to go to a longer space between versions of LIRADS. Our plan had been that we were going to do a version 2020. That was the goal. And then something happened. AASLD, which is the liver society that is responsible for providing guidelines and practice guidelines for hepatologists and gastroenterologists throughout the world, said, you know what, that LIRADS thing, that's a really good idea. Let's come together and we're going to endorse LIRADS. And so now we have buy-in from this huge population of physicians that take care of these patients throughout the world to endorse LIRADS. But we had to make a small change to make that happen. And the change is down here in the table. When we so we used to have this very complicated cell right here, the 10 to 19 millimeter observation that had arterial phase hyperenhancement, and one of these major features, washout and enhancing capsule or threshold growth, right? So you had to have one of those and you'd end up in this cell, which was split diagonally. And what used to live here was stuff like 5G, 5US, and it was a little bit confusing, I admit. And so now we haven't entirely decided what the little designations are going to be, but basically if something's in the cell and is either washout or washout or growth, it's going to be a LIRADS 5. If the thing in the cell is only capsule as that major feature, it stays as a LIRADS 4. All right? And so basically it matters which major feature that observation has. So if that one major feature that observation has is washout or threshold growth, you become a LIRADS 5. If that one major feature is capsule, you remain as a LIRADS 4. And I think that in some respects this makes sense to many of us, right? You know, when we see that 15 millimeter observation that was washing out, many of us kind of intuitively say, you know, that's a LIRADS 5, that's an HCC. I mean, and it's highly likely to be that. And that's what much of the hepatology literature also suggests. And so we're really excited to have this out there. It's going to be coming out probably in the next few months. The exact appearance of the table, the exact wording of the table may change slightly when we come to a consensus to what the best way to present this observation is, but essentially that is what the content is going to be. All right, so I'm going to go back because I wanted to make sure I got a chance to talk about this, but let's talk a little bit now. We're going to go back now and look at march through these algorithms. So you enter LIRADS and you talk about using LIRADS only in specific patient populations because that is where we feel we have the most validity and specificity for HCC. And so you only want to use LIRADS in patients who have cirrhosis, chronic hepatitis B viral infection, or have had HCC in the past. So that is our high-risk patient population. You should not be using LIRADS in the pediatric population, people that don't have cirrhosis or these other risk factors, or if they have cirrhosis due to vascular disorders like HHT, Budd-Chiari, chronic portal vein occlusion, because we lose our degree of specificity because these patients can have things that look sort of like arterially enhancing regenerative nodules. And so now we have two different types of things that can arise here. We have our HCCs that have arterial enhancement, but we also have these benign things that can also have arterial hyperenhancement, and we lose specificity in this population. So you don't want to apply LIRADS in people who have a vascular etiology for their cirrhosis. So we start out, once again, we assess, the adequacy of the examination, and we feel if for some reason something happened, for example, in this patient who had a lot of breathing during the arterial phase, you get the feeling there may be something there, but can I be absolutely certain there is arterial hyperenhancement? No, I can't necessarily, but I know there's something there because this patient got a hepatobiliary agent and there is an area of hypointensity that tells me there is likely to be an observation here. However, I can't tell you whether it's benign or malignant. Like, that's how spread apart the possibilities are for this entity. And therefore, you want to assign that an LRNC, non-categorizable, and suggest perhaps a different imaging modality to assess that observation. The TIV, which I've mentioned already, when you have enhancing soft tissue in the vein. And you also, once again, you want to make sure you report what you think it might be secondary to. HCC, non-HCC, or if you're unsure. And here's a nice example here where you see that kind of thread and streak enhancement of that soft tissue involving that left portal vein. 1 and 2 are for our benign and probably benign entities. I'm not asking you to report every cyst, every hemangioma in a patient that you see, but this is a very useful category for you if for some reason something was felt to be a LIRADS 4, 5, 3 on one exam, and now you get a different look at it with a different modality or just different circumstances, and you say, you know what, I actually think that's actually probably like a sclerosing hemangioma. Then you can therefore document that you have looked at it and decided it is a less degree of suspicion than it was previously. And that's usually the most useful application for these more benign type categories. And then LRM, which has existed in prior versions of LIRADS, but now we're giving you a little bit more guidance as to how to apply that category. And we talk a lot about rim and peripheral imaging features. And you can see that this is a replication of the overall morphology and cellular distribution of these observations reflected in different phases and different series. You see washout peripherally, delayed central enhancement, targetoid pattern of restriction, and targetoid transitional phase or hepatobiliary phase in hypointensity appearance. And so you can see the same pattern, the same morphology, just replicated in the different ways that we may image this observation. All right, so I am out of time. I wanted to make sure that you guys got to see that sneak peek of what's going to be version 2018. I really appreciate your interest in your use of LIRADS. Please continue to give us feedback as to how it's working for you. Please don't tell me that you're angry that I put out a 2018 instead of 2020. It's not my fault. We had to do it. It was time. Thank you.
All right, thank you, Cynthia. So I'll be taking us into the lunch break here with the last rapid fire session from this group. So I'll be talking about cases of bowel obstruction, no disclosures. So even though this is predominantly case-based, I have a few sort of break slides built in here for what I think are helpful when approaching patients with a suspected small bowel obstruction. So first question, is there a small bowel obstruction? In other words, is there a dilated small bowel proximally greater than 3 centimeters with decompressed bowel distally and a characteristic intervening transition point? If there is, take a look at the transition point and see if you can find any specific abnormalities that will help you identify the etiology of the obstruction. For example, is there one or more than one transition zone? Are there any specific abnormalities at the transition zone? Or is it in a particular location, like at a surgical anastomosis? And lastly, is there evidence that you have a complicated obstruction? Like, is it a particular type of obstruction that is unlikely to resolve conservatively? Or are there signs of bowel ischemia or perforation? So with that in mind, we have our first case, a 63-year-old man with acute abdominal pain. You have 2 images here plus a cine clip, and the question is, what is the most likely diagnosis? So we'll summarize the images here, which are labeled. We have multiple dilated loops of small bowel with an abrupt transition to decompressed small bowel distally. In the right mid-abdomen, there's a transition point with no visible abnormality at the transition point. So this is a small bowel obstruction caused by an adhesion. Of course, adhesions are a diagnosis of exclusion. We rarely see them on CT, but they're also the most common cause of small bowel obstruction. And they're exceedingly common, developing in upwards of 93% of patients who have undergone a prior laparotomy. So always the first thing to consider in a small bowel obstruction with no specific abnormality at the transition point. Next case, a 35-year-old man with abdominal pain and a lump in the anterior abdomen. So the question here is, where is the transition point? Terminal ileum, ligament of Treitz, surgical anastomosis, or ventral hernia. As I said, once you find the transition point, see if it's in a particular location that can give you a clue as to the diagnosis. So in this patient, we have dilated small bowel, which extends into a ventral hernia sac. The bowel exiting the hernia sac, shown in the upper right-hand image here, is decompressed. So this was an external hernia or a ventral hernia causing a small bowel obstruction. External hernias are the second most common cause of small bowel obstruction, most of which are clinically apparent, but in some patients, either because of body habitus or the location of the hernia, CT can be helpful to identify it as the cause of the obstruction. Here are a few other examples of external hernias causing small bowel obstruction. Another ventral hernia here, an umbilical hernia in the middle, and a femoral hernia on the right. Case 3 is a 25-year-old woman with Crohn's disease and abdominal pain. We have 2 images from an MR enterography here. So the question is, what best describes the findings? As Vinny alluded to earlier, this could devote an entire hour talking about the terminology, so I'll just give sort of a quick peek as to what we're talking about here. So here are your choices. Essentially the question is there active inflammation or not, and is there a stricture or not? So this patient had dilated small bowel with a transition point in the distal ileum. At the transition point, you see wall thickening with segmental mural hyperenhancement and luminal narrowing. So this was a case of active inflammation plus a stricture in the setting of Crohn's disease. Crohn's is increasingly noted as a cause of small bowel obstruction, essentially as external hernias are decreasing as a cause, Crohn's disease is increasing as a cause of small bowel obstruction. These are important to diagnose because there's potential for treating these patients with medical therapy to relieve the obstruction. Of course, many patients have chronic strictures or recurrent small bowel obstructions, and many of them will require surgical intervention. So again, this is beyond the scope of this talk, but just a quick plug to refer you to recently published consensus guidelines in radiology from the SAR disease focus panel regarding Crohn's disease and CTE and MRE if you want more details. Next case is a 60-year-old female who had a history of rectal cancer. The question for this case is, what segment of bowel is most susceptible to radiation? The stomach, small bowel, colon, or rectum? So in her, we had dilated small bowel, which extended to a transition point in the right lower quadrant, which you see here. At the transition point, there's thickened small bowel with mural hyperenhancement and wall thickening. And you'll notice that there's similar inflammation of the rectum posterior to this area. And you'll also notice that these findings are relatively similar to the case I just showed you, but the history is different. So this was a case of small bowel obstruction from acute radiation enteropathy. The answer to the question is that the small bowel is the most susceptible to radiation due to rapid cellular turnover, and there are acute and chronic manifestations of radiation enteropathy, with many of the findings overlapping those of inflammatory bowel disease, like you see here. Again, the history will hopefully be different and guide you to one or the other. Case 5 is a 63-year-old female with acute abdominal pain. We have 3 CT images here. The question is, what is the diagnosis? Postoperative ileus, emphysematous cholangitis, pyogenic cholangitis, or gallstone ileus. So in this patient, you see pneumobilia on the left-hand image, a small bowel obstruction with a gallstone at the transition point in the right mid-abdomen. So this is Regler's triad: pneumobilia, small bowel obstruction, and ectopic gallstone, resulting in gallstone ileus. The classic presentation here is an elderly woman with chronic cholecystitis who develops a fistula, allowing a stone to erode into the small bowel lumen and then impact distally, usually in the distal ileum or the terminal ileum, causing a small bowel obstruction. Case 6 is a 31-year-old male with crampy abdominal pain. Again, 3 CT images here to look at. So the question is, what is the diagnosis? Adynamic ileus, meconium ileus, constipation plus an impaction, or distal intestinal obstruction syndrome. So in this patient, you see fatty replacement of the pancreas, diffusely dilated small bowel with inspissated stool-like contents in the distal small bowel, and a transition point at the ileocecal valve here in the middle image. So this is in a patient with cystic fibrosis. This is distal intestinal obstruction syndrome. This affects adolescent patients with cystic fibrosis, where inspissated bowel contents accumulate in the distal bowel in the terminal ileum and cecum, resulting in a small bowel obstruction. This is also an important diagnosis to make because it typically resolves with conservative management, occasionally requiring intestinal lavage. Case 7 is a 76-year-old female with abdominal pain and vomiting. So we have a variety of CT images here. The question is, what is the diagnosis? Afferent loop syndrome, intussusception, peritoneal carcinomatosis, or transmesenteric internal hernia. So in this patient, we see dilated small bowel with a transition point in the right mid-abdomen. As I said earlier, once you find the transition point, look at the transition point to see if there's a specific abnormality that can tell you what the diagnosis is. And in this patient, we see serosal implants and peritoneal thickening along the transition point. And a follow-up PET-CT that was performed a week later shows that these areas are FDG avid. So this is a malignant small bowel obstruction secondary to peritoneal carcinomatosis in a patient with metastatic colon cancer. Malignant bowel obstructions are often a terminal complication of patients or for patients with peritoneal carcinomatosis, particularly when they're recurrent. This most commonly arises in patients with GI or GYN malignancies. Case 8 is a 43-year-old man with abdominal pain. 3 CT images here and a cine clip. The question is, what is the diagnosis? Afferent loop syndrome, intussusception, peritoneal carcinomatosis, or transmesenteric internal hernia, similar choices to previously. So in this man, you can see that he's undergone a gastric bypass, and we see isolated dilation of the biliopancreatic limb, shown on the right-hand side of the screen here, which is also not opacified with positive oral contrast. By contrast, the efferent roux limb is opacified with positive oral contrast and is not dilated. You'll see that the transition point here is in the left lower quadrant at the enteroenterostomy. So this was a case of afferent loop syndrome in a patient with gastric bypass. This is caused by an anastomotic stricture at the enteroenterostomy and results in isolated dilation of the biliopancreatic limb. The clue, as I said, is that you have isolated dilation of the biliopancreatic limb, which is not opacified with positive oral contrast, assuming you've given that particular patient positive oral contrast. And this can complicate gastric bypass, a Billroth 2 or a Whipple procedure. So just a quick break here, a non-exhaustive list of causes of small bowel obstruction with a single transition zone, broadly divided into extrinsic, intrinsic, and intraluminal causes, of which I've shown a few examples from each. Extrinsic can be adhesions, external hernias, anything along the serosal surface that can obstruct the bowel. Intrinsics include causes like inflammation, fibrosis stricture, neoplasm or intussusception, and intraluminal gallstone, intestinal secretions, or a bezoar. So now we'll move on to other causes of small bowel obstruction with multiple transition points, potentially. This is a 50-year-old female with abdominal pain. So the question is here, what type of internal hernia? I don't know about your institutions, but our institution, all internal hernias come with that question in the clinical history, so it makes it very easy for us. Anyway, choices are paraduodenal, transmesenteric, sigmoid mesocolon, or foramen of Winslow. So in this woman, you can see that there's clustered, borderline dilated loops of small bowel that are lateral to the duodenum with anterior displacement of the inferior mesenteric vein, which is indicated by the arrow here. So this was a left paraduodenal hernia, which is herniation of bowel into Lanzard's fossa, which is a potential space behind the fourth part of the duodenum, and a congenital failure of fusion of the descending colonic mesentery to the left upper quadrant peritoneum. The clue here on imaging is that you have clustered loops of bowel that are behind the IMV and the ascending left colic artery. Internal hernias in general are anytime bowel prolapses through a potential space or a defect in the peritoneum or mesentery, and these can be congenital or acquired from prior surgery. Case 10 is a 73-year-old woman with abdominal pain. So here, the question is, what is the diagnosis? Intussusception, adynamic ileus, closed loop obstruction, or a gallstone ileus? So in this patient, we have a C-shaped cluster of dilated small bowel in the right upper quadrant, and you'll notice on the right-hand image that there are overlapping or adjacent transition points at the entry and exit site for the affected loop. So this was an example of a closed loop obstruction. Anytime you have more than one adjacent transition point, you should think about a closed loop obstruction. The bowel essentially is obstructed at both the entry and the exit point where it's affected. And this typically has a radial configuration with either a C or a U-shaped appearance of the loop that's obstructed. These are high-risk obstructions because as the closed loop dilates and accumulates more fluid, you're risking initially venous outflow and then ultimately arterial flow, resulting in bowel necrosis. And closed loop obstructions can be caused by adhesions, internal or external hernias, or volvulus. Case 11 is a 79-year-old man with abdominal pain. And the question is, what is the most predictive of bowel ischemia? Bowel wall thickening, interloop fluid, absent bowel wall enhancement, or dilation of greater than 3 centimeters. So in this patient, we have a cluster of dilated small bowel in the right lower quadrant with engorgement of the mesenteric vessels, interloop fluid, and hypoenhancement of the affected segment of bowel. And so the answer to the question is that decreased wall enhancement on CT is the most sensitive and specific feature. It's been shown to predict bowel ischemia independently with a specificity of 94%, importantly even in patients who lack the typical clinical signs of bowel ischemia like leukocytosis or peritonitis. So if you see relative decreased wall enhancement in an obstructed loop, you should raise the possibility for ischemia. Case 12 is a 65-year-old female with abdominal pain and GI bleeding. The question is, what is the cause of obstruction, adhesion, internal hernia, serosal implant, or intraluminal mass? So in this patient, we have dilated small bowel in the right lower quadrant, and at the transition point, you see intussusception with an enhancing intraluminal mass corresponding to the transition point. So this was an example of intussusception resulting from an intraluminal lead point, in this case leiomyosarcoma, and resulting in a small bowel obstruction. As Erica said earlier, the majority of small bowel intussusceptions are transient and self-limited, are clinically inconsequential. However, if you see intussusception in the small bowel that results in a small bowel obstruction, those are highly associated with a lead point, so you should look for a lead point. So a brief word about complicated or uncomplicated small bowel obstructions. I think it's useful to divide these into sort of two categories. Uncomplicated obstructions are those with a single transition point without signs of bowel ischemia, and these are likely to resolve with conservative management. Complicated obstructions, on the other hand, are those that either have more than one transition point, signs of bowel ischemia, or particular types of obstruction, all of which are unlikely to resolve with conservative management and typically require surgical management or other intervention. So the last three cases are all going to be large bowel obstructions. The first one here is a 73-year-old man with abdominal distension. Apologies for the rapid fire cine clip here. I guess that fits our topic. But the question is, what is the diagnosis? Sigmoid volvulus, Ogilvie syndrome, stool impaction, or an intraluminal mass? So in this 73-year-old man, we have diffusely dilated colon with an inverted U appearance that you see on the radiograph and also the sagittal CT image here. And you'll note that the sigmoid colon is projecting above the transverse colon, which is indicated by the dashed line on the left-hand scout image. There's abrupt tapering and twisting of the sigmoid in the left lower quadrant. So this is a case of sigmoid volvulus. This classically affects elderly men who are obtunded or constipated, usually from either a long hospital admission or in a long-term care facility. These are high-risk obstructions also because they're closed loop, high risk for ischemia and bowel perforation, and the usual management is endoscopic decompression. Case 14 is a 58-year-old man with abdominal pain. So 3 images here, coronal and sagittal, and the question is, what type of hernia is this? Indirect, direct, femoral, or pantaloon, my personal favorite. In this case, we have the cecum herniated through a defect in the right lower quadrant, which is superior and lateral to the inferior epigastric artery and vein. You see mottled fluid and debris within the hernia sac. So this was a case of incarcerated indirect inguinal hernia involving the cecum. Of course, incarcerated hernias are diagnosed clinically, but we should raise the possibility of strangulation if you see hypoenhancement of the herniated loop or a lot of debris or fluid in the hernia sac. So a quick run through of the groin hernias. Indirect are those that are lateral and superior to the inferior epigastric vessels. Direct are those that are anteromedial to the inferior epigastrics. Femoral are below the inguinal ligament, medial to the common femoral vein, often with a typical teardrop impression upon the vein. And pantaloon are any combination of any two of these. So now our last case is a 54-year-old man with advanced prostate cancer. And the question is, what is the most common cause of large bowel obstruction? Colon cancer, external hernia, volvulus, or metastatic disease? So this man had diffuse dilation of his small and large bowel, and the transition point was deep in the pelvis where there was an infiltrative mass arising from the prostate and extending posteriorly in the rectum where the rectum was narrowed. So this was a case of a distal large bowel obstruction secondary to prostate cancer local invasion, resulting in a large bowel obstruction. So the answer to the question of the causes of large bowel obstruction, the most common is colon cancer, accounting for 60 to 80%, followed by volvulus and diverticulitis. Other less common causes of large bowel obstruction include intussusception, hernia, inflammatory bowel disease, or extrinsic invasion, like in this case. So that was my last case. We have a couple minutes.